All right, well, let's try and keep on schedule here. I'm going to reintroduce Dr. Jennifer Wells, who spoke with us yesterday. As a reminder, she is double boarded in OBGYN and psychiatry, currently practicing at the Virginia Tech Carilion Medical School, and she is going to speak on her favorite topic, substance abuse disorders and pregnancy.
Good morning again. Good morning. Oh, there's someone is up. Okay, so this morning, just like I promised, I'm going to talk about the subject that's most interesting me, kind of jacks me up. So I welcome anybody, questions, interaction that you have. This is sort of what I've dedicated my life of practice to. So here we go. So today we're going to start with a historical context of substance abuse. I think it's very helpful that we trace the history of opioids in the world and in our country, because we're going to see this disease has been around for a very long time, and women have been somewhat targeted since about 2 centuries ago. Then we'll look at our current opioid trends and epidemics as they pertain to the U.S. in general, to women specifically, and then to pregnant women as well. And then I want to talk about screening and brief intervention, because I think that's something that we're all missing out on. If we don't begin to have this discussion and we don't increase awareness, we don't increase the chances that our patients get help in treatment for this extremely important disease. And then we'll talk about treatment and some outcome research. So here is, if you look at anything dealing with opioid history, you're going to see pictures like this, because we know in the early 1900s there was a lot of, quote, medications, right, that were made to help women and children do better and feel better. And it's just so calming and nice, and it's natural. It comes from a plant, don't you know? So Miss Winslow's soothing syrup is a morphine and alcohol concoction that came around the turn of the century, the 20th century. And it was marketed to women and parents of fussy children as perfectly harmless and safe, providing a, quote, natural and quiet sleep for your baby. Just fuel them up with some opiates and some alcohol, and no problems for you at night. Problem sleeping for parents is a thing of the past. So let's look back at opium use was documented as early as 5,000 years ago. The Sumerians, who were very smart people, called it the joy plant. So from its earliest incarnation, right, there was something associated with opioids that was known to be quite good. Paracelsus is the one who created laudanum, which was an opium alcohol tincture around the 16th century. We know that opium was used commonly throughout the American Revolution, where there was poor hygienic conditions, right? So it was used often as an anti-diarrheal. Thomas Jefferson was someone who suffered from chronic diarrhea, and he used poppy so much and opium so much that he grew a limoncello. And there's a quote from him that said something about that it actually restored him back to his natural sense of himself. Right? So I think that's nice to keep in mind as we go forward about who's used opium throughout our history. And then in the middle of the 19th century, see that recreational use became more common. And I provide these up here because we know a lot of our opium at the turn of the 20th century was coming from the East, from Asia, India. And there was a particular marketing towards women. Right, because around this time there was, and somewhat currently, that, you know, women are sort of histrionic, always nervous, they can't settle down, oh my God. And we saw from that quote from the last lecture about, you know, if men didn't have to deal with the nagging and the, you know, the whining, and oh my God, they would turn to robotic sex people. Well, instead, how about we give women opium, right? Let's just settle them down. Everything's going to be okay. So you can see up at the top there, coming from there, right, a sarsaparilla that made women feel more relaxed, more natural. So, and the picture in the middle there is of an opium den. And a lot of opium dens around the 1900s targeted women. because it was a nice place to come and relax. You get away from the kids. It's a good feeling, place to hang out. And you can see, don't they look like they feel great? And so, and while Bayer doesn't like to acknowledge this very much, right? We know that Bayer used cocaine routinely as part of their in the creation of drugs as well as heroin. So it's not like we're far from the mark here. So in 1909, the Smoking Opium Exclusion Act was started, and that was sort of America's first stab at drug prohibition. And it wasn't until 1914, the Harrison Narcotics Tax Act, that things got really serious. So the Tax Act stated it was a federal registry created so that every person who produced, imported, manufactured, compounded, or dealt or dispensed, distributed, or gave away in any part opium or its derivative, it put them on a registry, and then it's ever going to levy a tax on you. And so it essentially required that all addictive substances be prescribed by licensed health professionals, and even under that guise was very, very limited. And so what the general message was, it singled out addiction as a moral failing, not a medical disease, right? So we see these drugs used throughout the centuries before, and then we come to the 20th century and we say, oops, hey listen, all those drugs you used before, you can't use them anymore, and you're a bad person if you do, right? That's a very powerful message. It made it nearly impossible for all the people who came before, who were using opiates regularly and with the consent of the law, to get treated now because they weren't available. Physicians were not able to treat for opioid dependence. That was not singled out as a cause to be put on the Narcotics Tax Act. So drugs then became a matter of law enforcement, not public health, as they had been for centuries before. Physicians who continue to prescribe opiates to addicts, these people, this giant population of people, as part of treatment programs, were actually put in jail. Women who were previously targeted to take a little bit of opium, take some laudanum, feel a little bit better, were then unable to stop using these substances and were forced to seek illegitimate sources for their habits. And then we know that when Prohibition was overturned in the 21st, as part of the 21st Amendment, the cocktail culture came back. So drinking became more acceptable, right? All of a sudden we get a surge in alcohol use in the United States, and heroin, which had been banned in the interim, became further stigmatized. So we saw that basically physicians are stigmatized and unable to prescribe people with substance use disorders any treatment because they're going to be put in jail. Women who were targeted as the main users of laudanum opium products are now forced to find illicit sources for their habits. And then we see when Prohibition's overturned by the 21st Amendment, drinking becomes much more acceptable, and that in turn stigmatizes heroin and opium use, which has now been banned in the interim. So those people are now stigmatized. Opiate users are marginalized as junkies. And so I made a tagline at the bottom that a century later, the practice continues. So this is just a reference point that there were multiple medications around the turn of the 20th century that, cocaine was a part of multiple drugs, as was opium, laudanum, heroin. So after World War II, synthetic opiates begin to enter the market, and we see an increase in recreational drug use around the 1960s surrounding the hippie culture, including a spike in heroin use by soldiers in Vietnam. Right, so we are currently in an opioid epidemic. This is not the first. It is largely considered the third, right? So the turn of the century is the first. Vietnam era vets, the second. And now we are emerging into the third opioid epidemic that our country has seen in 100 years. And as a result, for kickback from the use of all the Vietnam vets that were coming back addicted to heroin, the DEA is formed in 1973, and the Controlled Substance Acts came out just a few years prior to that. And so that's the culture we see. And then there's an interesting development over the next couple decades, from the 70s into the 90s, where doctors sort of become increasingly convinced that they're undertreating pain, and big pharma starts creating all these new drugs, right? Vicodin comes out, OxyContin comes out, and it's marketed to doctors, right? It's a different culture than it was now. Pharma used to walk into your office, they had huge sample boxes, like, ooh, here you go, here's 3,000 oxys. And those doctors were given financial incentives to use those drugs, and under the physician culture that maybe we're not understanding pain as well as we thought we were, doctors start prescribing more and more these new synthetic opioids. And so we watch as moving into this century that the prescribing of painkillers goes up. So here's a look at the opioid epidemics in the U.S. at the turn of the 20th century. We can see the numbers are pretty small, but the percent of women is about 66 to 75%, whereas in 2014 the number is about 50%. So the relative proportion has decreased, but the absolute number, 2.5 million, is certainly a lot higher. You can see the prevalence of opioid use disorder has gone up, right? We're nearing 1% as we come into the 2020s. So let's look at the current opioid epidemic, what's happening in the United States as a whole. And so as a whole, from the early 1990s, we're watching opioid prescriptions climb and climb and climb and climb. Right, there it is, just going up, 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 and we see just a little leveling around 12, 13. So the CDC estimates that there's 259 million prescriptions for opioids floating in the United States. So that's enough for every American household to have a bottle of pills available to them. So that's pretty scary. And I put these up because if you'll notice, the heaviest opioid prescriptions are occurring down where we are, right around our states. So one of the things that brought this to prominence, the opioid epidemic to prominence, is the the motor vehicle accidents fell below the drug poisoning deaths around 2009. So that brought a lot of heightened awareness from news media, from a public health standpoint, that, oh my gosh, this is something we really need to address. And if you look at unintentional drug poisoning deaths from 1999 to 2011, there on the bottom you can see we've seen a marked increase in opioid analgesic deaths, where there's some increase, right, with cocaine and heroin, but it stayed quite marginal in comparison. So what do we know about opioid use in women? The CDC talks a lot about it, and compared to men, women are more likely to report chronic pain. They're more likely to be prescribed prescription pain relievers for a complaint of pain. They're more likely to be given higher doses, to use them for longer periods, and to have a shortened duration between opioid use initiation and seeking help for an opioid use disorder. So what is that, right? That all tells us, it's like the making of someone with a substance use disorder. You give someone more pain meds for longer than they need them, at higher doses than they might need, and then you say, oops, that was too much, right? But the problem has already been established, so women are sort of in a very bad position with respect to opioid use disorders. So what does the opioid epidemic look like in women? So we see again that the opioid prescriptions rising a tremendous amount, and a tremendous number of deaths as a result of opioids in women nearing 2010. The CDC estimates for every 30 women who dies of a prescription painkiller, for every woman who dies of a prescription painkiller overdose, 30 go to the emergency department for painkiller misuse or abuse. That's astounding. And if you look down here, every 3 minutes a woman goes to the emergency department for prescription painkiller misuse or abuse. So our ERs are being flooded with these people who have a tremendous problem that needs to be dealt with, and we're not doing an adequate job at this point. So where does opioids in pregnancy come to national attention? We see that the deaths have increased, so what prompts all the attention into pregnant women is the fact that it's costing a lot of money when women who are pregnant and are substance users have babies, and those babies then have a problem withdrawing from the drug that they've been exposed to. So this is a study looking from insurance companies
of exposure to opioids in pregnancy, and you can, oops, I keep doing that. You can see that it's pretty high. There's somewhat of a trend maybe going down from 2010 to 2011, but it's still tremendous number of people, right? We're on the average of 13% of all pregnancies surveyed by a national insurance company, and then also, right, the heaviest use down in the south of the United States. And we know that the treatment for opioid use disorders in pregnancy is only going up. So you can see major trends from 2000 up until present that female admissions are up, proportion of opioid use among pregnant women is up, and treatment during pregnancy is up. So again, if we look at our prescription opioid use among pregnant admissions, how many women who are coming in are on opiates already? There's a trend increasing over the course of the last decade, and the South is leading the way. So here we come to why has it gotten national attention now, and it's because all those women who are getting hospitalized, who are getting treatment during pregnancy, then have babies that are exposed to opiates in utero and are suffering from a condition known as neonatal abstinence syndrome, right? We recognize it as a consequence of exposure to opiate use in pregnancy, and this is costing our system quite a bit of money. You can see the rise of NAS birth and the rise of opiate use. So the CDC just put this out as well. Every 25 minutes, a baby is born suffering from opiate withdrawal. That's a 5-fold increase since the year 2000. So that's a huge number, and it's a very costly increase. When these babies are born, the current standard of practice is that they go to the NICU. So the NICU is very expensive. And if you look down here, oh, good Lord. If you look down here, the number of, the length of the hospital stay, right, is increasing by like 2 weeks. 2 weeks in a NICU is a very expensive stay. And then if you look at the price, right, we've gone from, a couple $1,000 to $50,000, $60,000, $70,000 for a single infant. So that's not something our hospitals can sustain. So why did I get interested, or why do I think this is so important? Substance use in pregnancy is a widespread problem. Again, it's like I talked to you about yesterday in psychiatric disorders. If you think you have a particularly happy population that's feeling real good and you don't need to give them any help for psychiatric disorders, it's not that that's the case. It's that you're not asking the right questions, or you're missing the diagnosis, or we're not talking about it enough. And the same is true of substance use in pregnancy. Women are using substances in their pregnancies not because they want to, because they have a disease and it needs to be treated. So in pregnancy, right, we have a very unique time period in a woman's life. It's like the cross-section of their, life cycle with their reproductive life cycle with the substance use life cycle. You get this unique period of time where you can intervene. It's also good, women who are pregnant, right, have a lot of contact with social institutions, right? They're open to a lot of federal funding. They have universal health care. They often go to prenatal visits. Almost, every woman wants to take care of her pregnancy. So while she might not be the most compliant with getting to services in general, it's a great time to intercede. There's a lot of medical attention, there's a lot of psychosocial interventions, and there's a lot of funding in programs to help women who have any issues in pregnancy. So your window of opportunity to affect change is really great. So I want to encourage, since I'm speaking mostly to a primary care population, that we start the discussion. We start the screening for substance use disorders. And how we talk to our patients is really important. And this is something that I sort of keep reminding myself on a daily basis. It's very hard to talk about substance use disorders in pregnancy. Women feel inherently sad and ashamed that this is a problem they have to deal with, and they don't wish to talk about it, and they want to hide, and they never want you to ask. And it is your job, right? It's your imperative, that's the word I want to talk to them, to say something, to open up the discussion. And if they lie, well, that's okay, right? Then they're not ready to do it. But it's our job to begin the discussion, to create an atmosphere that feels pretty safe. And I admit sometimes that's very hard. I do this every single day, and I find it hard sometimes to get the truth out of women. But so I think how we talk to our patients is important. So this is a news article out of the Wisconsin Journal Sentinel. And in the history, we're watching the history of opiates, right? Women are stigmatized for using. We sort of targeted them to use opiates to feel better, get calmer, right? And then we pull it back and then we say, you are a bad mother for using. And it's a really delicate balance. So the headline of this is a parent's heroin addiction, a newborn's death sentence. To me, that's a little heavy-handed, right? So a mother uses opiates, probably not of her choosing, right? She has a disease, and I understand that sometimes is hard to bring into our medical culture, the idea that substance use is a disease because it has behavioral symptoms, behavioral outcomes of use. But in fact, if we look at it as a disease, this woman has a disease, right? And her child has sequela of that disease. But it's certainly not a death sentence, right? It's treatable, recoverable, and we move on from that. But I do think it's still important. No bystander could be more innocent, no damage so helplessly collateral. I think that's fairly accurate. But this is where we come out of, this is what we set up in the 80s, right? This is the mother who's using drugs. There's a crack epidemic, and we targeted African American women, and we posted sort of shameful pictures of these women pregnant, abusing drugs, babies off to the side, and we create this social stigma against discussing drug use and pregnancy. So what I try to do when I talk to my patients is to use appropriate medical language. Substance use and substance use disorders is the current DSM-5 criteria for how we talk about drug use. I use addiction because it's very much part of our regular language. I try to avoid the word addict, and I'm going to say right now I'm kind of bad at it, but I really do try because I think it carries a stigma all on its own, right? All news media, when people speak derogatorily about persons who are using substance use, oh, she's just a drug addict, right? It's a very easy off the tongue thing, and it has a negative connotation almost across the board. So I try to stay away from it. I try to stay away from substance abuse simply because our DSM criteria, our medical language is moving towards substance use disorder. So that's where I try to use. And then I explain this over and over again to my patients that substance use disorders, addiction, is a brain disease, right? We have charted this. We have mapped it. We know this. This is not a question anymore, but it has behavioral symptoms as a consequence, right? So the manifestations of this disease happen to be crime, further drug use, sexual promiscuity, the transmission of other diseases, right? Those are social behavioral outcomes. But the nidus of the problem is still a disorder located in the brain that is targetable, and though not curable yet, it is treatable. So that's the language I try to convey. And I try to be kind of open style, non-judgmental, and compassionate. I mean, I do this every day. Usually when a woman is coming to me, she's sort of already aware she's going to have to talk about her substance use. For you guys, they might not know. And so you have to be careful when you're talking about women who are using substances in pregnancy, right? They're already stigmatized and marginalized. They feel horribly ashamed for their attitudes. And the way we've set it up in our culture, as I've gone through with you, is that it's a discriminative policy, right? We've treated people very poorly, and I'm going to review that. Our criminal justice system treats pregnant women who abuse substances different than anybody else. So this is state policies on substance abuse during pregnancy. And the left half of the screen sort of looks at the criminalization, the policies that are used to criminalize women who are using substances in pregnancies. And you can see 18 states currently have policies for reporting substance abuse to the state during pregnancy, versus on the right side of the screen, how much insurance companies, how much state policies are looking to treat women. So pregnant women given priority access to general programs, there's 12 states. So 18 states are going to try to penalize you, criminalize you, take away your child. That's what the mother reads it as. Versus 12 states that are like, we're going to try to get you to some help and try, right? It's not a mandatory, it's a we'll try. And then, sadly, 4% pregnant women are protected from the criminal justice system, right? So using publicly funded programs. So that's pretty sad across our nation, right? We want to put these women up for scrutiny and review of a problem that most people get to walk around and get treatment for. So 38 states currently have feticide laws. 23 have laws that apply to the early stages of pregnancy, right? We, in fact, do criminalize this behavior. And the problem is that the punishment doesn't fit the crime, right? All these policies work to separate the maternal-fetal dyad. I'm sure you guys in this room recognize moms and babies work together, right? There is no separation. The fetus doesn't exist without the mother, and vice versa. So the idea that we're going to establish policies to separate them doesn't seem natural nor effective. And probably for all of you that know or have dealt with women who have substance abuse, they don't want to be using in pregnancy. It's sort of virtually pathognomonic that you have a problem if you're using in pregnancy. So we need to keep that in mind, right? The laws that are currently in effect, right, are discriminatory in its application. We looked at the social media intent of like the crack epidemic and who they targeted. So substance use disorders affect everybody, but white women are more likely to use in pregnancy. That's just statistics. But poor women are far more likely to be prosecuted and incarcerated. The same with African American women, right? So we have a problem. That's sort of like, the death row argument. It's not grounded in evidence. The harms of illicit substances tends to be exaggerated, and the effects, why women are using, tend to be minimized. So from that are a lot of unintended consequences, right? Women who are abusing substance don't want to come to the doctor because they're scared they're going to get punished, and they rightfully should be. So we need to bring further attention and awareness to the idea so that you're talking about it, so we recognize just how pervasive it is, so that we get help. Because in fact, women who abuse substances, who get prenatal care, use less substances. So let's try to do that. So what happens when women who use substances get pregnant? So we can look at a lot of different substances. Cigarette use in general tends to go down. Alcohol use tends to go down. And if you look at from 2007 to 2012-13, right, the national data goes down on the whole. Binge drinking goes down, heavy drinking goes down. Illicit drugs. Now here, we're in the midst of an opioid epidemic. So we're not surprised that the use rate is going up. But in combination, in evaluation against non-pregnant people, it's still half the rate, which is pretty good. So if we look at substance abuse by trimester, we see that in general, people who are using substances during their pregnancy try to cut down as the pregnancy progresses, right? Is that in line with what you guys see? Generally, yes, right? Because women who are using substances who get pregnant don't want to be using substances. They want to try to stop, and the data supports that they're actually doing that. So let's support them. So this is adolescents, and not surprisingly, we see that adolescents kind of use it a little bit more. But they're a young, high-risk population that requires a lot of education and probably gets fairly little. They're the ones who seek access the least. And as we saw in Oklahoma, is it? There's a lot of ways still to go with them. And if we look postpartum, right, the return to use, the relative proportion of substance-using women who abstain during and after pregnancy, right, we see post-pregnancy a return to use of 80% go back to using. So in some respects, right, that's sort of disheartening. Oh boy, a lot of people are going back to using. But as a single intervention, pregnancy is responsible for a 20% reduction in substance use. I don't know about you guys, but that's a pretty fantastic number for something we're largely not responsible for. So I'll take it. So when we look across the whole of these statistics compared to non-pregnant women, pregnant women drink less alcohol, they smoke fewer cigarettes, and they use fewer illicit substances during pregnancy. Use decreases over the course of the pregnancy, so as we progress through trimester, it gets less. The greatest reduction is seen earlier, so pre-pregnancy to first trimester when they first find out. So that's when you can make the biggest impact. So that's a real stimulus for us to talk about it as soon as we find out a woman becomes pregnant. And as I said, 80% resume postpartum, but that's still a full 20% who aren't doing anything at all. So that's pretty fantastic, right? Rehab. $100,000 rehabs aren't that good. So, my message, if you hadn't gotten it already, is that most pregnant women are motivated to maximize their health and that of their baby-to-be. If a woman cannot quit or cut back during pregnancy, it's because she has a substance use disorder, and that needs to be treated as such and not criminalized. So I like that little picture I found, healthcare, not handcuffs. All right, so what are we treating when we have substance use disorders in pregnancy? So the greatest majority of people that we see are actually marijuana users, right? We're watching the opiate epidemic increase, so we know that that's going to be high, but it's actually marijuana. And I don't know about you guys, but in my community, I have a lot of pressure. My OBGYNs don't wish to screen for substance use disorders in their private patients because they don't want marijuana users criminalized. That's a big problem coming up for us. And all I can do is just encourage, right? I personally don't think it's a good idea to smoke marijuana during your pregnancy. I don't think you guys probably think that as well. And so I say to my practitioners, we're not doing our patients a service if we just ignore the problem and see if it will go away. So who are we looking for? Who's being treated? Characteristically white women who are unemployed, who do not have legal consequences to date. They have less education rather than more. They tend to use multiple substances. About a quarter use IV drugs, and a full 30 to 40% have a comorbid psychiatric diagnosis. Yeah. No, I mean, it's not good. But for my business, something I like. That did not come out well, did it? You get my drift. So when we look at women with substance use disorders in pregnancy, 2/3 have co-occurring mental health disorders, right? So that's a big number. In the past 30 days, mood disorders account for 50% of those cases, anxiety 40%, PTSD 16%. 60 to 80% of these women have past year intimate partner violence. Right, so we also know that chronic pain is worse in IPV survivors. I don't know how many of you see this. This is a very, very common thing in my practice, that the great, great majority of women with serious substance use disorders have a history not only of current intimate partner violence, but have been the victim of childhood sexual trauma. And that is a terrible thing to have to work through. It's very hard therapeutically to manage. It's hard from a psychiatric, psychotropic perspective. But if we don't identify it and we don't get them the help they need, then they're sort of sentenced to using drugs perhaps for most of their lives. So there's the childhood traumas. I don't know if you guys are aware of the data supporting adverse childhood events and the contributions those have to psychiatric diagnoses, including substance use disorders. It's profound and important, and probably something that you guys talk about in your offices as well, or hear a lot, because it affects sexual practice, it affects mood, memory, cognition, and sort of getting through your life having to deal with the trauma of the past. So we know from a reproductive health standpoint that most of these women who are pregnant and using substances didn't intend to be pregnant. Because if they had planned it, they probably would have planned it at a time when they weren't using substances, if that was something that was an option for them. They generally have low rates of contraception. Most of these women have high rates of smoking. I mean, I come from Virginia, right? So the smoking population, I've never seen so much smoke in my life. But they also, it's additive, right? They use a lot of different substances. And in terms of social functioning, they don't have good coping skills, right? They have few social supports. It's so profound, the number of people who come from sort of like a drug culture in their family. Everybody's popping pills. You know, if you get a hangnail, you know, your mother-in-law's like, did you want a Xanax? Right? I mean, this comes up so often in my MAT groups, in my medication-assisted treatment groups, that the family, it's a culture of how we use drugs and how we make ourselves feel better, that we take an illicit substance, and that's how we move on with our day. And it's hard to combat that when you take a singular woman who doesn't have a lot of financial support, who's being abused by her husband at home, whose family is handing her drugs whenever she complains of a headache, and ask her to be clean and abstinent, and that's the best thing for your baby, so just do it, right? It requires a lot of social support on our part. These people, as you can well imagine, have unpredictable parenting models, and their children, right, are the legacy of all this, right? That's what they then grow up in. So they have poor parenting. They don't know how to take care of the children. The children are often left without proper care. So, as you can imagine, it's a complex set of patients with a unique set of needs. So I love that our previous speaker said, you know, women are complicated. So women who are pregnant, who use substances, are super complicated. They require special care and treatment. And the gold standard nowadays is the idea of a comprehensive co-located service delivery system, right? So it's having a psychiatrist in an OB office, sort of a care home or a centralized service that has access to substance abuse referral and treatment. So my practice, I sit part-time in the actual OB clinic of my 800-bed hospital. And if the doctors and PA see somebody that they think needs referral, they're referred directly to me either that day or within the next couple weeks for treatment, for assignment to whatever they might need. So as we've discussed earlier, early identification and screening is key, right? You have to find these women, because the earlier we get them into treatment, the better the outcome for both themselves and for the baby. We want to screen all pregnant women, but also all reproductively aged women for substance use disorders, and all women in substance abuse treatment programs for their pregnancy plans, right? It's a single question. Are you planning to get pregnant this year? Or do you have any plans for having a child in the coming years? Have you thought about what it might be to have a child, right? All those things need to be discussed, and I think I do a pretty poor job. I don't know how you guys feel, but in general, we're sort of not meeting the need. Yeah?
I just wondered, how do you approach the subject of screening? Do you tell the patients that they're all going to be screened?
So you just hang on a minute. So here's a cute quote. Wow, I'm 9 months pregnant. That went by fast, said no one ever. Right, so we have a long period of time for these women, 10 months basically, if they come into treatment, to have a discussion. And I admit, it's hard. So how do we screen for substance use disorders? I want to point out that universal screening is recommended, right? ACOG said in 2011 we should universally screen for alcohol, and in 2012 they brought forth their recommendations for prescription opioid screening. Selective screening based on risk factors perpetuates stigma and misses most women with problematic use, right? If you look in and you're looking at someone and you're trying to determine if they use substances, right, you're probably on the wrong track. We need to ask every single person. It needs to be just part of your routine screening. So I think it's interesting. You guys do a lot of screening for a lot of diseases, right? If we look at it, though, the prevalence of those diseases pretty rare in some cases, right? But a lot of time, a lot of blood work is spent counseling these women and making sure they know the risk factors associated with their pregnancies for getting HIV or birth defects, anemia, preeclampsia, where if you look below at the prevalence of substance use disorders, right, averaging 5 to 15%, in most women, and we don't screen for it. Not universally, at least, right? So we need to add that to the conversation. So why is it hard? So women, as I've said to you before, right, they're afraid of discrimination. They're afraid of your judgment, right? They know you're going to think they're bad people because they already feel like bad people themselves. They've had previously bad experiences with health care. I can't tell you the number of things I have witnessed as a psychiatrist in my own hospital, walking one of my pregnant MAT patients, someone that I prescribe buprenorphine for, into L&D to hear a nurse say behind the curtain, she's a drug addict, this is going to be hell. I mean, it's astounding, and I've heard it multiple times. So I know it's occurring elsewhere, right? And it just needs, these women, their fear is real. It is true. They fear child protective services, right? Every woman is certain that the CPS or DSS is coming into their hospital room the second that baby's delivered and handing them a sheet of paper that says you no longer have parental rights. It's the thing that they've, had a nightmare about for 10 months come true. And then there are the people, right, that don't think they have a problem. They've been using just fine and they happen to get pregnant. It's just another bump in the road. Let's just, continue on as normal. And then what's our problem, right? It's hard to talk about. Number one, we tend to believe our patients don't use drugs because we sort of don't want to know, right? Denial is as powerful in our patients as it is in us. It's also, we're all under time constraints, right? I see my follow-ups in 20 minutes. I'm not sure what you guys have to do, but it's hard, right? This discussion is a fairly detailed one if it's going to be held as a full discussion. But what I want to say and what we're going to talk about is that it doesn't have to be, right? It can be very short, brief, 4 minutes, and you're done. So, and then a lot of, I think, physicians fear, like, what am I going to do if they say they have a problem? Like, I don't know what to do with them. And is it really going to help? Like, are they going to do anything anyways? Like, are they even going to show up for the next appointment? And it's sort of fatalistic, and it's sad, and we need to have a little more faith in our patients, even though this population, I can tell you, will test you every time. So, in general, patients aren't offended if you ask questions about substance abuse, if you do it in kind of a, laissez-faire attitude. Like in my practice, and I say it's probably a bit biased, like they know what they're coming to me for. So I think they're used to talking about it. But I sort of just lay it out there like, hey, listen, my job is just to get a history. And if I have to, I can say to them, like, here are the CPS guidelines in the state of Virginia. That's not something you guys need to do, but I can do that. Say that they're not coming to get your child. Everything that's in here is a confidential medical record under HIPAA. It can only be subpoenaed by a court mandate. And it's never happened in the history of my career. Right? So there are reassurances I can give them. But in general, most women, if you just say, hi, I add this as part of all my screening questions, like, have you been screened for HIV, hepatitis C? Do you use any substances? You smoker? How about alcohol? Did you use any early in your pregnancy? It's just, it's just one of the many questions you ask. You just throw it in there. And if they raise their eyebrows, you just say, I use this with every single patient I do. I hope it's not offensive. Right? And generally, I think they just move on. They don't worry about it. I ask, this is something a colleague of mine does, and I'm not sure how I feel about it. Asking permission. Is it okay if I ask you some questions about smoking, alcohol, and other drugs? Because the caveat is if they say no, you have to respect that boundary, right? Because that's what we do as physicians. If your patient says, I don't want to talk about it, you have to respect that boundary. And in my line of work, I don't ask. Because in general, you're here to see me because you need substance abuse treatment. And if I don't have the full history, I'm obviously not going to offer it to you. So I don't know. You could test it out in your practices to see how it works for you. But my colleague swears by it. So, and that's coming out of Baltimore Health, Mishka Turplin. And you, right, we all want to try to avoid close-ended questions like, are you drinking? You mean you smoke? You don't smoke like every day, right? Those are loaded. So I mean, a woman's going to look at you and be like, right? And it just rolls off their tongue. They're used to lying to a lot of people because that's how they protect themselves. It's a lot of fear-based culture in substance use. So there's been screening instruments that have been designed for pregnant women. It can be done as part of the patient interview. You can give it to your patients prior to coming in. So like in our office, we give them a PHQ-9 and the 4 Ps, which is Chasnov down there at the bottom. Oops, I did it again. Oh, there it is. So right there, the 4 Ps down there. So you can use screening tools, but I think if you just ask basic open-ended questions, you're going to get the exact same information, but I provided them there for you. And so what about urine toxicology? So ACOG came down and said it should not be used as a sole assessment of substance use problems. And in general, for the pregnant population, I'm not sure it serves much good, right? There's a short detection window for nearly all substances of abuse. So you're not going to catch binge or intermittent use. You're not even always going to catch daily use, depending on the timing of the test. They don't detect alcohol, which is the second most abused substance. And it rarely captures prescription opioids unless you use a drug screen like I do, which is drug screen 15, which is a very long, comprehensive drug screen. So in general, it's not needed. The questioning is all you need to do. I use it every day in my practice because I'm treating women after the delivery for use in MAT, so for surveying how they're doing with their drug treatment when they're already in a drug treatment program. And then there's some ethical issues surrounding drug screening that are still being worked out. Our hospital is still working through the ethical issues of could you screen all pregnant women that come into the hospital with a urine drug screen at the time of admission? And so far, our lawyers say no. And then there's differential testing too when the baby's born. Can you test the placenta, the meconium, and the baby? And ours is differential screening. So if you have a number of risk factors, that triggers the test. So for a summary of screening, right, drug use is very common. It's costly. It's associated with many diseases. So in pregnancy, drug use is more common than many other conditions that you guys routinely screen for. So I can't say enough that it's time we do universal screening. It's also recommended, right, by basically everybody, but it's rarely performed. So 70% of prenatal care patients report being asked about smoking and alcohol. So a full 30% aren't being asked about drugs that have, much more frequently in social circles. And so if you compare that to like opiates, cocaine, right, we're probably talking about them much less. So there's this whole new screening protocol called SBIRT. Has anybody heard of it? Yay! So that's great. So SBIRT is a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk of developing these disorders. Right? So SAMHSA is rolling out a big public health protocol to try and bring SBIRT to all hospital systems. And it doesn't have to be used for substance use alone. It can be used for any behavioral intervention. So it's a process. The SBIRT is screening, brief intervention, referral, and treatment. And the idea is that you ask your patient screening questions in a brief but comprehensive manner. So brief, 3 minutes, right? That's based on motivational interviewing. It's a technique that's used to then get patients who need services to services in less than 5 minutes. So the idea, the major thing to take away is that of all the patients you ask about, right, the great majority are going to say they have no problem. They're just fine, right? Because the majority of patients you see still, we're talking about, 10 to 15% of your population, so 85% doesn't have a problem. Most people don't have drug and alcohol problems. Of course, the risk depends on who you're treating, right? My patient population has a much higher percentage, but in general, it's fairly low. So your goal is to just identify people at risk and get them to get help. So there's a demographic, right, of all the people you screen. Only 4 people might require brief intervention, some motivational interviewing, a couple of questions to generate the idea that maybe they need some help, and 1 actually requires a referral to treatment. So that seems much more manageable. And I also wish to say this doesn't have to be done just by physicians, right? You can train any member of your office staff to do it. all associated personnel can be trained in the SBIRT technique and can pass this information along to a physician and then have someone in the office deal with the referral to treatment. So the burden doesn't have to be all on your shoulders. I know in my hospital, our psychiatry department is rolling out SBIRT training for all the residents and all departments across the hospital to try and increase substance use screening throughout our community. Okay, so now we'll probably get to the meat, why everybody's really here, and that's treatment of substance use disorders. So what is the consequence of substance use disorders in pregnancy? You guys are probably all aware of this. Alcohol is really well documented, as is nicotine. So in opiates, we're talking about NAS, neonatal abstinence syndrome, and as we go further, the terminology will probably become NOWS, neonatal opiate withdrawal syndrome. So you'll see them used interchangeably. But in general, right, if you use substances, your baby is at higher risk for having problems, and predominantly low birth weight, and we know that low birth weight has a lot of sequela to the life of the child going forward, so it's nothing to be treated lightly. And we know that the consequences are additive. So in this slide, if you're looking at the dots on the right that are over the median, that's the additive effects of both smoking and drinking in pregnancy, right? It leads to even smaller babies with more problems. So if we were to add, those are the two most common, if we're to add opiates, cocaine, methamphetamine on top of that, you can imagine the consequences are fairly significant. So what are the principles of substance use disorder? There's two main ones, right? Behavior and pharmacology. We do know, as I said to you before, substance use disorders, it's a brain disease with behavioral symptoms. So we have to treat both the behavior and the brain. And that right there is just a small picture of the addiction pathway. So the standard of care is MAT, or medication-assisted treatment. Medication-assisted treatment is done with either methadone or buprenorphine in addition to counseling. So the federal guidelines on opioid treatment programs just came out, and it said it is crucial that pregnant women engage in treatment for their addictions. They should be given priority to admitting pregnant patients at any point during pregnancy and providing them with all necessary care, including adequate dosing strategies, as well as referrals for prenatal and follow-up postpartum services. So who in their community thinks we're meeting that standard? No one, because we're not. Right, I don't know if you know, but I don't know of any directive in my community where pregnant women are identified and given priority treatment into programs for their substance use disorders. So that's pretty sad, because that's what I do. So if anybody would probably know in their community, it's me. And just so you know, you don't have to meet DSM criteria as a pregnant woman with a substance use disorder to be included in MAT. It probably only pertains to people who have buprenorphine licenses in this room, but it's an interesting idea that we want women to be treated as early in their substance use disorder as possible. So you don't have to meet criteria for dependence to get treatment. Are there buprenorphine providers in this room? Simcox. So there's another woman in the back of the room, Dr. Simcox, and she and I work at affiliated hospitals in the Virginia area. So we're representing Virginia today. So why do we want MAT in pregnancy? What are the benefits? So we know that women who are using substances in pregnancy who don't seek treatment, right, are forced to go out and find illicit substances. So what that results in is a drug high, an intoxication, then a withdrawal. An intoxication and a withdrawal, and we recognize that that's more dangerous for the fetus. Giving buprenorphine provides a stable intrauterine environment, no cyclic withdrawal, no erratic opioid levels, and we also know that it leads to a decrease and a cessation in illicit drug use, right? We're talking a lot about harm reduction here as opposed to total abstinence. But with this harm reduction comes a reduction in infectious disease transmission, a reduction in high-risk sex behaviors, a reduction in intimate partner violence, a reduction in sexual trauma specifically. Women who are treated in MAT programs have increased prenatal care. And part of that is probably because medication-assisted treatment programs are fairly intensive. I require contact with all physicians who my women see throughout their pregnancy They come to see me every single week. We have an hour therapy session with 10 women in my office every week. We do a drug screen every week. They are given a prescription for 7 days of medication, and that is all. If they miss a group, if they don't see me, the only time they can get their prescription is if they see me in person in the days following. So it's pretty intensive care. But we get better pregnancy outcomes, increased maternal weight gain, increased neonatal birth weight, increased gestational age, which are key triggers that tell us these babies are born healthier than babies who are not given MAT. There's a decreased risk of overdose, right? Particularly if you're giving someone who's on buprenorphine, right? Buprenorphine has a ceiling effect. We'll get to it, but so they don't overdose. It's virtually impossible unless you're really smart, which a lot of these people are. But they're motivated not to, partially because of their pregnancy and partially because of this treatment program. We also, as I said to you, they're open to other supportive services. So I do. A lot of my women come through a federal program called Project Link, which is federal programs that are established throughout the United States, but these women have access to full case management services. So in addition to getting MAT, they also have counseling, psychiatric referral, case management, child care, parenting classes, vocational support, transportation. So it's pretty holistic, which is a great thing. So MAT in pregnancy, if you weren't sure that it was something that was beneficial, it's supported by every major health agency that is in the world, basically. So what do we use? We use methadone or buprenorphine. I can speak more to buprenorphine because that's what I use, but methadone is the gold standard. It's the only FDA-approved medication during pregnancy at the current time, though the standard of care has come about to establish that buprenorphine is a safe and effective alternative. Serum methadone levels and elimination half-life are influenced by pregnancy, so sometimes dosing needs to change as we go through the pregnancy. But in general, both are stable alternatives for MAT. Buprenorphine is a mu-opioid receptor partial agonist, an agonist-antagonist, so it has a ceiling effect. So methadone, if you keep increasing the dose, the person gets bigger and bigger high until such point that they're comatose. Buprenorphine you don't experience that. You hit a high, and in most people, I've just changed over all my pregnancy prescriptions to, anyways, I've changed over all my pregnancy prescriptions to Suboxone, which is a combination buprenorphine naloxone cross product that prevents high from IV injection. It's not really, it's something just if you're treating that you need to know, but in general, buprenorphine becomes a safer alternative because of that. So which medication do you use? And a lot of attention has been given to this subject in recent years. We know that a lot of studies have looked at neonatal abstinence syndrome and the effect of using methadone or buprenorphine on the babies. So is neonatal abstinence reduced or worsened with either drug? Is the hospital stay reduced with either drug? Are the weights of the babies increased more than one over the other? So a lot of data has gone into that. And we know, as I said to you before, that there's a lot of attention to this cause, right? Because neonatal abstinence syndrome has grown nearly fivefold since 2000, accounting for $1.5 billion in annual hospital expenditure. So it's a very big deal that we're trying to get a handle on. And so what they look at when they're looking at the comparison of these two drugs is the age at delivery, birth weight, head circumference, the prevalence of neonatal abstinence syndrome, which is diagnosed using the Finnegan scale, days of treatment for neonatal abstinence syndrome, and the length of stay, right? Because once again, that's very important because they are often in the NICU, and that's a very expensive place to be. So what do we know? When looking at the mother data, which is this singular biggest 6-site study about this, it comes up that they're relatively equal on par, with the exception of some important factors. So buprenorphine probably, if we look at all the data, probably has less severe NAS, so it makes it very attractive for hospital systems. There's a reduced risk of overdose during induction, right, and that has to do with the ceiling effect. You can only go so high, and there's a reduced risk of overdose if children are exposed to the medication, which becomes increasingly important because most of my women who have these problems have multiple children in the home and they're exposed. I'd like to say my women, put their prescription bottle up high in a locked thing, but I have more than one case where a child has been found holding the tablet about to put it in their mouth, which is tremendously scary if you think that could have been an 80 milligram methadone tablet. So for my recommendation, I use buprenorphine, and that's what I've switched, but also because the dosing of methadone in the United States is now done by federal clinics or private clinics, and so it's harder to do in an in-office structure, and buprenorphine has sort of been catered to help physicians build into their office practices the use of it. So what I want you to take away is that neonatal abstinence syndrome, right, it's not a disease. It's not that the baby is addicted to drugs. It's that it's an expected and treatable complication of substance use disorders and medication-assisted treatment in pregnancy, and we have strategies for dealing with it, and it is treatable and curable in the infant. So there you go. It has no long-term negative outcomes. We know that 50 to 90% of opioid-exposed neonates experience neonatal abstinence syndrome, but we don't know who they'll be. It doesn't seem to be dependent on the dose a mother gets of either methadone or buprenorphine. So it's sort of a shot in the dark, and we think there's probably a complex interaction between multiple drugs, smoking, substance use, even SSRIs, preterm delivery, the genetics of the infant and the mother. So we can't really prevent it from happening, but we know how to treat it. So in summary, all pregnant women, I want you to take away, are motivated to maximize their health during pregnancy, right? They know pregnant woman wants to be using substances, shooting heroin, searching for drugs so she doesn't go through withdrawal, right? They all want to stop. If they don't stop, it's because they can't stop. So they have a substance use disorder. So that's when we need to be talking to these women. Your brief screening comes into play. You get them a referral to treatment. So they come to someone like myself or another practitioner in your community who might be able to manage them. And I just think in my practice, these women are needing of our support and our compassion, and they're wonderful people who really want to do right by their children, but have very, very limited skill set by which to do so. So our compassionate, non-judgmental, comprehensive, and coordinative care is really something that is their birthright.